preventable maternal and newborn mortality and stillbirth, as formulated in the Sustainable Development Goals framework. Next slide, please.
You can move the slides yourself, Blätter. I can't move them.
I'm trying, but it's
go to there's a little arrow above all the slides. It says 02. Okay, let me take back control and do it.
Yes, please. So now we are seeing the definition of quality of care. In a way, quality of care is summarized and it describes the 6 critical attributes that are namely safe, effective, timely, efficient, equitable, and people-centered. Next slide, please. The conceptual framework that we are using provides the foundation for our quality improvement efforts. The centerpiece summarizes 8 domains in which actions are required to ensure quality of care. Each domain is annotated by standards with quality statements and measures that describe quality of care. On the left side, we see domains that specifically pertain to provision of care. On the right side, we see domains that pertain to experience of care. Both provision and experience are essential for the outcomes we intend to achieve at individual and facility levels. Next slide, please. To translate this conceptual framework into practice, we as a network have articulated 4 strategic objectives. Those are the leadership, action, learning, and accountability. Next slide, please. An implementation framework summarizes the steps through which we operationalize these objectives. At the top, we see a systematic series of steps, starting with national policy, strategy, and structures, which lead into the plan, do, study, act cycle, PDSA cycle, at the level of health services. Now, in our previous session, Dr. Nigel Lipsley of USAID ASIS introduced the implementation interventions that have shown to be effective to improve quality of care and illustrated how we can move towards the network goal of halving maternal and newborn deaths and stillbirth in health facilities in 5 years. Today's guest, as earlier introduced, is Professor Ashok Dorari. Dr. Dorari is professor at the Department of Pediatrics, a WHO collaborating center for newborn training and research at All India Institute of Medical Sciences in New Delhi, India. Professor Dorari is a passionate teacher and steers a multimodal education program in neonatal health in Southeast Asia. He pioneered web-based education to help dissemination of evidence-based newborn practices. He is a well-respected clinician and scientist who continuously and actively contributes to generation of evidence and knowledge. Nigel, I pass back to you the presentation and introduction of Dr. Dorari's step 1 in the implementation cycle.
Great. Thank you very much, Blätter. That was great. So just a couple of housekeeping things before we get started. So if I'm going to put everybody back on mute, but please don't unmute yourselves. We want to be able to hear the presenter. Okay, so now everyone's on mute, and please let's keep it that way. The second thing I want to talk about is later on in the presentation, Ashok has a poll. And we're going to raise hands to give what we think is the answer. So let's just practice that now. So to raise hands, you push the chat button, which is near the top right of the screen. And then there will be a symbol that lets you, thank you, Anna. Anna has figured it out. So if everybody could practice that. If everybody could go to chat and then raise your hand. Abigail, thank you. Ben, thank you. I won't thank everybody, but Prabir, thank you. Francis, William, Joseph, excellent. Great, I think people have it. All of the S's. We don't have any of the S's raising hands. Sahil, Shailanda, Smita. Oh, there you go. Thank you, Smita. Okay, good. Thank you, Yuriko. And Zainab, we won't wait. So that's great. Thanks very much. So when we come to the slide where Ashok is asking a question, we'll get a poll from everybody, and then we'll give you the feedback on how many people said what. Okay, so the hand icon is next to the mute, unmute button if you're not sure. So if everyone now could put your hands down, that would be great. So, and then the final thing is at the end, we're going to have a discussion. So if you can type any questions you might have for Ashok into the chat function, then Bene will read all of the questions and Ashok will answer them. It's too chaotic to ask them verbally, so please use the chat function for that. And if we don't get to answering your question, then Ashok will write the answer to them and they'll go back up on the website. Okay, great. Thank you very much, everybody. So I'm going to hand over to Ashok. And he's going to take us forward. Great, so you're the presenter now. You're the presenter now, Ashok, and you are unmuted. Please go ahead.
Hello, friends. Greetings from All India Institute of Medical Sciences, WHO Collaborating Center for Newborn Education and Training and Research. Today's presentation will be done by myself, Ashok Deorari, and Meena Joshi. As a team, she is a nurse educator with us who leads quality improvement initiative in Indiana.
Sorry, Ashok, can you just switch your presentation? We're still seeing Blair's presentation.
It's not coming?
No. So just switch tabs on the top.
Okay.
And welcome, Meena. Thank you for joining us as well.
I can see.
Now we can see perfectly. Thank you very much.
So greetings from All India Institute of Medical Sciences, New Delhi, WHO Collaborating Center. So point of care quality improvement, POCI, is a simplified 4-step approach for improving quality of care for mothers and newborn in healthcare facilities. This tool is developed by All India Institute of Medical Sciences, WHO CRO, and USAID assist technical experts. The tool uses 4-step approach. The step 1 is identifying problem, forming a team, and writing an aim statement. Step 2 is analyzing the root cause of a problem and choosing measurement indicators. Step 3 is developing and testing changes in the form of plan, do, study, and act cycle. And finally, sustaining improvement of the gains we make in the quality improvement project. Today, in step 1, we will learn to pick something specific to work on, form a team, and develop a precise aim statement. The learning objective for today's session are how to review data in a healthcare facility to identify a problem, how to prioritize which problem to work on, how to form a team to work on that problem, and how to write a aim statement. You may be able to find many problems once you look for them in a healthcare facility. One should use local data from your health facility for identifying problems or gaps in care. Because quality improvement is new skill for many people, it is important to think of the first improvement project as an opportunity for learning. Because of this, new teams should work on quality improvement projects which are easy to work on, simple to solve, do not need additional resources, have a fast turnabout time so you can get the result quickly. It is crucial for good outcome for patient care. That means it is impactful. One should not take in the beginning projects which are more complex, projects which have long turnabout time, and projects which require follow-up. These can be left for later stage once you develop the QI skill methods. Let us look at a birth register of a healthcare facility. This shows the data of 10 mother newborn diets in the form of name, date of birth, time of birth, delivery route, use of uterotonic given within 1 minute, Apgar's 1 minute and 5 minutes, birth weights, temperature at the 1 hour of age, immediate drying of the baby which is done or not, delayed cord clamping which is followed or not, date and time of birth, and whether the patient needed a referral or had a complication. And if we look at this birth register data, we come to know there are a lot of gaps in the quality of care which is happening in this healthcare facility. We notice gaps in quality. See in red blocks here, out of the 10 deliveries which have taken place, uterotonic has been given only in 50% during the first 1 minute. Look at the yellow blocks here. Babies at 1 hour of age who are hypothermic, temperature below 36.5 is in nearly 50% of the newborn babies. Look at immediate drying in the green box here. Nearly 70% of the babies are getting dried at the time of birth, and it is lacking in 30% of the babies. Similarly, if you look at difficult problems which are not under our control, like low birth weight, is happening in 2 out of 10, that means 20%. And in 2 out of 10, there was postpartum hemorrhage which is reported. Once you have lots of problems in a healthcare facility, you need to prioritize. And for doing prioritization, a simple mnemonic which can be used is picker, which means you find out, write down what the problem is, try to evaluate it, how much impact, value this will have for patient outcome. C is for look whether it is under the control of the team. E is it is easy to do. R is it requires resources in the terms of extra money, or it saves time. Now here is a possible aim which is being shown, or a problem which is being shown, like uterotonic which is given within 1 minute for a delivery. Now, if we have to prioritize this, along with our team members, what we need to do is, we can give a score of 1 to 5 for each of these 4 domains. First domain is importance to the patient outcome. The second is whether it is affordable in terms of time and resources. Second is it is easy to measure. or it is under the control of team members. So we can give a score lowest of 1 and a highest score of 5, so that a total score out of 20 we can give for prioritization of this problem. Look at, it is given by the team members. They give a score for importance to patient of 5, affordable in terms of time and resources for 5, easy to measure 5, under control. So total score out of 20 is 19 for use of utrotronic, which is given within 1 minute of age. Look at another possible aim or a problem which is there, like management of postpartum hemorrhage. Management of postpartum hemorrhage is very important. It is impactful, so it gets a score of 5. It is affordable in terms of time and resources. It gets a score of 4. It is easy to measure. No, it is difficult to measure and quantify it, so it gets a score of 2. Is it under control of team members? No, it is somewhat under control, so it gets a score of 14. Similarly, for a third problem, immediate drying of baby at the time of birth of the complete body by a dry towel gets a score of total of 9. If we look at another problem of delayed cord clamping, it gets a score of 15. A low temperature at 1 hour of age gets a score of 19. And then decreasing low birth weight below 2.5 kg gets a score of only 12. The reason is this is not under our team's control. It is not easy and affordable to control this. So it is getting a lower score of 12. So based on the consensus, we arrive that the maximum score is got by 3 of these possible aims or the problems. The first is use of utrotronic within 1 minute of delivery. Second is immediate drying of the body of the baby. Again, it gets a score of 19. Low temperature of the baby at 1 hour of age below 36.5. Again, a score of 19. So based on this consensus, there are 3 problems which have to be tackled in this healthcare facility. But best is, out of these 3, we need to take 1 problem to be sorted at one point of time. Now we have understood how to identify a problem based on looking at a data which is available in the healthcare facility. It is coming from a register. Many times the problems can be identified from the case records or from the computerized system database if that is existing. And then we also learned how to do prioritization using a mnemonic of picker. How much impact this will have, how much it is in control of the team, how much it is easy to be done, feasible, and how much resources is. So one can do a prioritization of the problem which need to be tackled. And for doing this, once we have picked a problem, what we need to do is we need to make a team. And team members should be picked based on how they can contribute to reaching the aim. Team has greater power than a single person to make a change. We should look for people who are enthusiastic. Try to get members who want to work on this aim and have ideas for how to reach it. Look for volunteers. People who are interested in making changes will self-motivate. Look for people who are involved. Make sure a lot of people on the team are doing the hands-on work that needs change. People do not like being told to change, but they like changing and improving themselves. So have them on the team. Having more workers rather than managers will make it easier for change to practice. Have in the team influential people. Look for team members who are able to involve and influence other people. Having a diverse is good. One should have a wide range of people in the team. Staff, such as cleaner and helpers, can also contribute depending on identified problems. Similarly, you may need to include community members, people accompanying patients, if a problem involves cultural or behavioral issues in clinical care. Titles and hierarchy should not matter while you decide to make a team. You want people who understand the problem and have the ability to change how the care is going to be delivered. It is also good to assign different roles to the team member. We need a leader in the team and assigns responsibility, who directs the activities to achieve the goals. He represents the team. We need a recorder who maintains the written records of the team discussion and the decisions taken. He records the meeting notes. We need a communicator. Communicator communicates and liaisons among other team members. In addition, we need a person like a data manager, or this role can be taken by one of the team members who collects and analyzes data to determine if there is resulting improvement. Healthcare is delivered in a complex environment by a range of people. Healthcare workers who will have to change how they work their existing practices should be in the team. Involving a whole range of people will lead to a wider range of ideas for how to fix problems, thus increasing chances of success. Involving people in the process of change early reduces resistance to the change. People do not like to be changed by others, but are willing to change when they get to decide how to change, once they learn how easy to make a change. Accomplishing leads to increased team spirit and confidence to address bigger problems subsequently. There is no ideal size of a team. Generally, a good team consists of 4 to 6 members. Keeping too many people or too few may be less effective, even harmful for the quality improvement project. Now we have learned how to identify problem, how to prioritize, how to select the team to address the problem. And once the team is formed jointly, we need to develop a precise aim statement that clearly states that needs to be achieved, and it should say clearly what needs to be improved, who linked to a patient group, whether it is newborn or mother in labor, how much should be measurable, and include a clear, achievable target and a goal, that is, increase coverage, suppose from 20% to 80%. By when? Includes a definite timeline. So a good aim statement is SMART. It is specific, measurable, achievable, relevant, and timely. The structure of aim statement is in this form. We should write down like this. We aim to, what do you want to achieve, should be written there, in which patient group, from what is the current level of performance, from what percentage, to what is the desired level of performance you want to reach, by how long, after how much duration. It should be 4 weeks, 6 weeks, or 8 weeks. Now, in a healthcare facility, as we noticed there was a problem that all babies are not right immediately after birth. So a good aim statement for this would be, we aim to implement standard practice of immediate drying in all births from current level of 70% to 100% by when 1 month. So this is a timeline. Now, we will do a polling here, and we would request you to raise your hand. Here is example 2. And we ask you, is this a good aim statement? The aim statement is written here. To establish skin-to-skin contact after delivery in low-risk mothers admitted in labor room of your hospital. Please raise your hands.
Great. So we have about 50 people on the webinar, Ashok, and 3 people have raised their hands.
So that means majority of the people say it is not a good aim statement. That is great.
Yeah, Ashok, we have a comment here saying it's not a good aim statement because it's not smart.
Yes, excellent. So this is not a good aim statement. As majority of you, 47 out of 47 are saying it is not a good aim. The reason being, it is not specific, does not mention how long skin to skin has to be done, is not measurable, does not have a target, and does not have a timeline from where you have to improve. Now read this aim statement. To establish skin-to-skin contact immediately after delivery for at least 1 hour to an extent of 25% in 2 weeks in low-risk mothers admitted in labor room of your hospital. How many of you say it is a good aim statement? Please raise hands.
So we have 21 people raising their hands. So almost half of people.
Oh, yes. So nearly half of the people are saying it is a, yes, I agree, it is a good aim statement because it provides the definition of what is meant by skin-to-skin care and a target to improve by 25%. And it also gives you a timeline of 2 weeks. So this is a good aim statement. So to establish skin-to-skin contact immediately after delivery for at least 1 hour to an extent of 25% in 2 weeks in low-risk mothers admitted in labor room of your hospital, it is a good aim statement. Now at this point, now let me call Meena Joshi. She's nurse educator with us to tell you real stories on quality improvement work which we have done in our NICU, and we have mentored many other healthcare facilities where quality improvement work has been done, how we identified the problems, and how we did team building. Over to Meena Joshi.
share how we built team and pursued quality improvement project at AIMS. To ensure and engage team members, regular meetings were conducted, progress of project shared using display of data, sending SMS and WhatsApp reminders. Heads of the department faculty were kept informed with the progress of work. To motivate team leaders, opportunities were provided for sharing their work in workshops attended by doctors and nurses team. At one time, we engaged multiple team members and different teams in QI projects. The problem to be solved were chosen by nurses and resident doctors. We were mindful that the QI projects, which are easy and don't need resources, have values for patient care to be chosen for improvement. Ideas emanated during clinical ward rounds and baseline data were collected from existing case records or computerized inventory. Here I share a true story. One team did QI project for increasing duration of KNC for sick premature babies care under warmer. Team consisted of mothers, nurses and doctors. Team met regularly and during ward rounds reinforced KMC through audit on nurses' record of each shift. While the KMC QI project was scaled, we noticed frequent breakage of warmer temperature probe. Despite education of nurses and diligent nurses, probe life remained short. But once mothers were educated using flip charts and about the breakage of temperature probe, so the breakage of temperature probe decreased. Thank you, and we are now open for question and answers.
Great. Ashok and Mina, thank you so much. That's great. So I'm going to hand over now to Bene, who will be reading out the questions that people are asking. So please just type your questions in the chat box. Type them, send them to everybody so everyone can see what questions are being asked, and then Bene will be reading them out in order. Let me just. Oh, Bene, you're off.
That's fine.
Okay, great. Yeah.
Thank you, Nigel. Thank you, Ashok and Mina, and Berta earlier for presentation. So the questions started coming while you guys were still talking. The first one was actually a comment from Abigail saying that this example of your second aim statement where people raised where people voted that it was smart actually was incomplete and was not smart because it didn't state a baseline. Do you want to comment on this?
Yeah, so yeah, it did not mention the baseline, but we said improve by 25%. So whatever was the baseline, we are saying improvement by 25%.
Okay. Then we have a question from the maternal child team in WHO, so Zainab and Berta, asking from your experience, to what extent do team members consider QI as a contribution to their professional development? Did you hear that, Ashok and Mina?
Yeah, yeah.
Okay.
So it was to.
I'm sorry. To what extent does addressing QA, or do people consider QA as part of their professional development?
Yeah. So whenever we want to do quality improvement, I think quality assurance piece need to be in place. We need the structure, the system, the protocols, SOPs have to be in place while you want quality. So the QI goes with the QA together for providing quality of care.
Yeah. Okay. They keep coming in. So we have a question from Lani asking you how to balance the importance of addressing a problem with high impact value and the importance of addressing something easy to fix. So, what do you choose, the easy stuff or the most important, difficult issue that will have more impact?
So I think whenever we are choosing a problem, we look at a problem discuss with the team what is easy to fix without asking extra resources, and it is in control of the team members who are working in front line together. And once it is coming from the team members that it is easy to fix, they don't need resources, they want to work all together as a team to fix it, we choose those type of problems. And as we said, we can use the picker method, the mnemonic, for giving the prioritization and discussing among the team members what has to be done.
Then a question or a comment actually from Dr. Rishabh Kumar Rana, explaining that often in facilities staff is really overloaded. So how do you address this when QI team requests are just another request, another priority? And he was saying specifically of the facility and the staffing facility in Bihar and Jharkhand.
Yeah. So I think it is so important that if we are working in a health facility where we don't have the required number of staff nurses or doctors who are working in that health facility, then doing a QI becomes an extra burden to the healthcare professionals. So we need to ensure that we need to have the required number of staff nurses and doctors which are posted in that healthcare facility. Then only they can take on this work of doing quality improvement. Meena? So there is a question to Meena Joshi on, besides KMC, what are the examples of quality improvement projects in your facility? Meena? Yeah.
Besides KMC, we have even before KMC, we have done one project on express breast milk, and we have increased from our baseline 30% to 83%, and it for last 2 years we are able to sustain it. And the second one was on KMC, and the other, like I already mentioned, on temperature probe. The remaining, like we are doing on reduction in alarm volume in NICU, and we have from 30, like in a, it was the alarm was get activated 30 times in an hour. Now it has reduced to 1 or 2 alarm over 1 hour. And the other project which we are doing are on communication skill and medication error and follow-up counseling of the mothers.
So Meena, there is another question for you. People are asking, how do you motivate your team members to do quality improvement work?
Motivating team members is first when we are choosing the team, at that time we take those members who are interested and those who want to work. So once we frame a team, then we do regular meeting and we display our data on weekly basis to the team, and then we organize like champions, and we distribute certificate of a contribution, and showing data to the mother, to the nurses, and involving like HODs and sharing data, showing results, and all these motivate nurses, and then awarding them like certificate of appreciation. So all these keep on motivating nurses.
Good. Meena and Ashok, there is a question more specifically on data, and asking what the place of the WHO standard and the assessment based on standard is in generating data, so that health can tackle that problem.
Yeah. So there was a question on what is the role of standard of care by WHO in quality
generating data.
For
data.
So the standard of care by WHO which are created, we need to collect that data and information, and if those standard of care are not happening, like doing skin-to-skin care or delayed cord clamping, and if these are gaps in providing evidence-based care to the newborn babies at the time of birth are not happening, so we need to take that as a problem and discuss with the team, create a team, and then make quality improvement projects for improving those evidence-based practices so that they are applied to majority of the mothers and newborn babies.
Mm-hmm.
So there is another one question from Doug Macmillan. You mentioned projects should be short. Do you have more specific? Okay. So what we normally advise people is try to have quality improvement projects which can be shown and gives you result over a period of 4 weeks or 6 weeks. Doing projects which are long projects which will run for months together or maybe 1 year, in which you are trying to collect outcome data, which it makes the whole process a little bit more complex. And if we do projects which are small over a period of 6 weeks or 8 weeks, and we can show that we are able to get positive gain and improvement in patient care, it motivates the team more. They do more projects, and then maybe at a later point of time, they can take projects which can be of longer duration, 6 months, 1 year, or maybe they can do like collaborative projects which can be between different units, can last for years together. I hope that this is for Doug.
Thank you, Ashok. You have a number of questions on motivation and how it's required to kick off and manage a QI project, but people have very conflicting priority and limited time. So how do you find motivated people? How do you make sure that their part of the motivation goes to QI? Ashok, I've lost you. Ashok, I think we've lost you. Meena as well.
Changing the slides. Hi, Ashok. Meena. Let me just text them, see what's happening.
Mm-hmm.
Can you ask, what was the question again?
The question was about motivation, so how to find enthusiastic people, and also how to, because you add on work to existing team and existing task, how to keep the momentum for that.
Right. Yeah, those are great questions. So I think that's why it's important to not be too structured. You know, look for people who do want to do this, and try and pick aims that people are interested in. You know, and that's why it's nice to give them some flexibility. So people are motivated to do work that they want to do, and so give them a chance to do that. And often it's helpful to focus on things that make their life easier. You know, we try to do work that is causing them problems so that they have a chance to fix that and make their life better. So it's not just improving care for the patients, but it's improving their life as well. The other thing that's important is to share results and to be very positive. Most health workers in facilities rarely get told what a good job they're doing, and QI is a good way of changing that. You know, they're fixing problems that have never been fixed before, and even a little step in that direction should be praised, you know, to the heavens. So that's useful. And then once they start getting results, and again, you'd like to get results within weeks, you know, they will have something to show their supervisors and their patients, And that's very motivating as well. So, start with easy stuff, get some success, praise that success, and then give them things that make that success visible that they can show other people. I think those are the keys.
Thank you. There is a more question, in fact, about measuring and defining what results will look like. So, from Doug Macmillan again, do you think there is a role for defining number of patients rather than time for a QA process?
For a QA, I think definitely for testing things. It's often good to say we're going to test this idea for the next 5 patients, or something like that. So that's very sensible. So yeah, I hope that answers the question. Oh, Ashok, are you back?
Ashok? No.
Let me just. Ashok, are you back? There we go.
Oh, good, because there is some very specific aims question that are addressed to you and Mina. Ashok, one is in aims, are we practicing ENBC practices? And are there any change in labor room practice like partograph? So specific example that you could share with this group. You need to unmute Ashok, maybe. He does. If we don't manage to get Ashok back on the audio now, I see 3-4 questions which are related specifically to presentation and aims, and we'll share that with him later, and we'll answer them and post the answers on the website like we did last time, so we don't miss any of these important questions that this group has raised today.
Yeah, we got connected just now.
Nigel, Ashok can speak, so I have another question that you may be able to answer because it's broader, not just aims. Do you have any tips for sharing success with administration to promote recognition and similar process? And sustain QI.
I think that's a good question. So one is pictures. Drawing run charts that we'll hear about next time that show the improvement is very useful. It's a quick way of getting a lot of information across, so administration can look at that very fast. And the second is to come up with simple stories about this. Most people are not so interested in the process of quality improvement, all of the tricks that you did to fix the problem. But they're interested in the results, and they're interested in the stories about what you worked on to get there. Those are the key things. I also think you need to put the results into context. Talking about simple percentages, we moved from this to this, may not be that appealing, but saying we kept, another 40 babies each week warm since we did this. Can be good. So think about who you're talking to and put it in their terms. Go ahead, Ashok.
In addition to this, what we do is whatever quality improvement projects have been successful, we make this as a policy statement which is signed by the head of the department and shared with the administration. So they are kept informed that this department or the unit is doing multiple quality improvement projects which are sustained in the system.
Mm-hmm. Yeah. Ashok, good to hear you back. I think we can take two more questions before we wrap up. One of them is a broader question on training, as a role of training in case of poor practices. What can training do, and what kind of follow-up is needed and monitoring for QA approach to keep being relevant and effective?
So in situations where there is poor practices which are existing, I think putting quality improvement work does more of like you can do mentoring, supervision, and ensuring best practices are applied in the healthcare facility. The quality improvement team can provide that support from a remote place or connect to the people where those practices which are not being used or applied can be connected with WhatsApp, and the teams can be engaged for doing better work.
Yeah. Thank you. Dr. Prabir Ranjan here is mentioning the role of champion and ambassador for QI who can demonstrate results, but also their know-how on how they got there. Any comments on this?
Yeah.
Any comment on the role of champion and ambassador for QI?
I think I mentioned earlier, you need a champion or a leader in each and every healthcare facility to provide the healthcare, and that person should be able to make his team do improvement work in addition to providing the basic healthcare which has to be provided as a standard of care in that healthcare facility. Mm-hmm. So the quality improvement work which is done in a healthcare facility, it adds on to the standard work which people are doing, and it tries to make people do better work and improve on existing work what people are doing. And there are a lot of problems which are existing which come in forefront while the team members start discussing those problems, and then the team members themselves try to find out what the solutions are, and they are able to test, and we will learn that in step 2 and 3 in this POCI tool.
Yeah. One last one for you, team, for everybody who presented. From Shilandra, this is most of the time she's seen QI team working at facility level, but she wants to know if that example was senior program manager involved.
So I think it's crucial to involve the senior program managers, because whenever you do quality improvement work, many times or most times it needs a system change which has to occur. There is system support which has to be required for sustaining the quality improvement gains in the system. For that, it is very important that program managers need to be exposed to what quality improvement methodology is. In addition to, they already know what quality assurance piece is, which relates to the system, the manpower, the supply, and the SOPs and quality assurance piece which has to be in place. So the program managers are very crucial, and if they know about this and they know the teams who are the frontline worker who are doing good quality improvement work, then your team gets more motivated to do more and more improvement work in the healthcare facility.
Thank you. Before I hand over all the power to Nigel, I wanted to say 3 things. First, it's amazing how many questions and the depth of questions that are coming today. I realize we didn't answer every one of them, but as discussed earlier on, we are going to follow up with you on the one that we didn't have time to answer, and they will be posted on the website. I'll thank everybody. The link to this, the link to the audio recording, and the presentation. Second, This is where step one. We have a whole series of webinars lined up with the partners of the Quality of Care Network. This is the second webinar. There are more coming, and you will be invited to the upcoming one through May and June. And then there will be another series, which is more focused necessarily on point of care quality improvement. And thirdly, and I completely forgot what my third point was. No, I think that is that the follow-up that you will get through email from the team. Nigel, over to you.
Great, thanks very much. So Ashok and Mina, thank you for a very clear presentation on the importance of starting with specific and fixable problems, the importance of getting teams together of people who are interested in working on this problem and helping them pick a specific aim statement. So yeah, in the next 2 weeks, you'll get an invite to the next meeting. So the next meeting will be Pierre Barca talking from IHI, talking about once you've decided what problem you're going to fix, how you start to work on that, how you look into what is the cause of the problem, and how you go about measuring so you can start to fix the problem. So thanks to the audience as well for great questions. Ashok will be answering in writing. Ashok and Mina will be answering in writing the ones that we didn't get to, and they'll be up on the website. But thank you very much for your engagement and commitment. So thanks very much, everybody. Goodbye.
Thank you. Bye-bye.
Thank you. Bye.